And once I can do that, though, I can teach it. Like I had to drive to Charlotte, and that's what I was doing. I could visualize what I wanted to do. So, but with this, okay, we're going to look at the diagnoses. So, guess what? There's a lot of questions on this, right? But we're going to look at that. We're going to look at signs and symptoms. Okay, in particular, the nurse needs to address. We're going to look at, in particular, interventions, and we're going to pull those meds in, okay? Now, I will tell you, in your book, there's like a chart, right? It's like 2 pages. So you need to look at what is the med, in particular, short-acting, right? Is it used for an acute situation? Or is it really for long-term maintenance, prevention, you know? Because that's huge. That is huge. And you also need to look at, you know those little things that are on the side where it says kind of what the, you know, what the nursing stuff should be? Yeah, and that's what you want to really look at. In particular, side effects, and I'm going to try to point those out with our interventions. We're going to look at nursing interventions and our collaborative being our physician's orders, okay, and in particular meds for you guys. Okay, you should already, what we're going to do, we're applying the process. That is how you were tested. Okay, so your big diagnoses, do you know these? Right? That should pop right into your mind when you're thinking about patients diagnosed with the following disorders. Okay? So, ineffective airway clearance, impaired gas exchange. Is that a priority? Yes. Yeah, it's a priority. Okay? It takes priority over anxiety and fear. Okay? So, you want to always think of these as a priority diagnosis. Okay? Now, we're going to look at, let's first look at asthma, okay? Big thing with asthma is, can it be reversed or no? Yes. Yes, that is the critical key point of asthma. It can be reversed once it's identified early and treatment is initiated and they maintain treatment. We do know from your case study that asthma can be triggered by irritants, right? That could be things that, in particular, the child is allergic to. It can also be what? Secondhand smoke. Okay, smoking is still the big #1 risk factor. Okay, so oftentimes in your children, you're going to see the incidence of asthma based on the exposure to secondhand smoke. Maybe both parents smoked and, you know, they grew up with that, and then, you know, as a young teen or whatever, they developed asthma as they started, you know, playing football or real strenuous exercise. Now, with this, we know that this allergen or irritant triggers what? Remember, you got that bronchial constriction, inflammation, that can initiate bronchospasm. You've got increased mucus production. So now, instead of having this nice open airway, you've got this what is that? Wheezing. Ah, that's the air trying to go through, okay? Those airways. Now, the thing that a patient needs to learn that, guys, that is not any indication of the severity of the disease process, okay? So they're wheezing, right? And we're going to talk about with our interventions what the patient should do, right? That's where we're going to get in with our peak flow meters, right? And our inhalers and things like that. So now we have got this young adult out playing football, okay, is having an asthma attack. What if it's lasting longer than what?
30 minutes.
What is that? Status asthmaticus. Is that a medical emergency?
Yes.
Yes. You want to know why? You may not hear wheezing. Exactly. It's a medical emergency. So we want to try and teach our patients to prevent these attacks so they don't end up with a status asthmatic case. Although I will tell you, we are considered the, allergen belt of the country, and we see people oftentimes when those pollen counts and all the things like that get so high around here, and it puts them in the hospital because of the triggers. Okay? Now, so what signs and symptoms do you identify? Wheezing. Okay, dyspnea. Increased heart rate. Cough. Increased mucus production. And if it continues to get worse, what will you start seeing? Those retractions and the nasal flaring. Okay, that's when you know we're in trouble. Okay. So right now, I just want you to look at the causes and let's identify kind of the signs and symptoms and the little brief patho. Okay, with that. So again, you got this. It's reversible. That's the critical piece. Now, when you look at this term, COPD, that is an umbrella term. Okay, it really is an umbrella term. Why? Because under that umbrella term, we include emphysema, chronic bronchitis. But you will often see that umbrella term used in your documentation, okay, and in test questions, okay, because that's what we think of, okay, when we think of COPD. Reversible or no? No. Okay, and that's why the patient picture now becomes different, okay, because this is, as you said, this is irreversible. Okay, irreversible, irreversible. Okay, now by understanding, and again, big risk factor is smoking. Okay, it can be also like long-term environmental exposures, things like that. But in this country, this is the biggie: smoking. The thing that is different about emphysema, okay, is those irritants from smoking, they release, and this is just FYI, they release what is called protease. And if you get high levels of protease in your pulmonary system, it causes the elasticity of the alveoli to not be there. Okay? So you lose the elasticity of that alveoli, well, all of a sudden you've got these. Right? You got this is now in your lungs. So you may, and guess what? If the alveoli loses its elasticity, can it do what it's designed to do?
No.
No, it cannot. So as this continues over time, you are actually losing surface area for gas exchange to occur. Okay? And because of that, you're going to see, remember, it's 1 to 2, where you're going to see 2 to 2. The barrel chest. And because of this, actually what happens is their diaphragm flattens, so that makes it harder for them to get air in, but in particular, air out, and they assume, what is this called? It's a tripod position. Tripod position, okay? Irreversible. The damage is done. These are very interesting patients to work with. And what I want you to visualize is the pink puffer. Okay, remember the pink puffer. They've got what? The barrel chest. I didn't write those down, I should have. Barrel chest.
Shortness of breath.
Okay, shortness of breath, dyspnea, pursed lip breathing. Did y'all talk about that? Why that's you're trying to clear that CO2 more effectively. Okay, so pursed lip breathing. Okay, maybe tripod position. Right, I just mentioned that. Okay, from the increased work of breathing. Okay, and nutrition can be depleted because when your life revolves around breathing, it takes all your energy. Okay, so their nutrition can be depleted. They can have very thin extremities. What is their color? Pink. Almost like a ruddy color, okay? It's from the lack of oxygen in the blood. And what else will you see? Clubbing. Clubbing. That's due to the lack of oxygen to the tissues over time. And it'll actually, once you see it, you'll know it. It's that nice rounded, it looks like a club. That's what they look like, okay? Now, let's also talk about what type of ABG are we going to see.
Mostly normal.
If it's early, you just told me they have a hard time. CO2 is increased. So, and PO2 is decreased. So what happens to pH? pH decreases. So you have a respiratory acidosis. Now, I will tell you guys what happens over time, long periods of time, is the bicarbonate will rise to normalize the pH. So these patients live with that elevated CO2 and a low O2. Okay? They live that way. So can you go in there and put a high amount of oxygen on that patient? Why? Exactly. Their drive to breathe, our drive to breathe is changes in CO2. Their drive to breathe is the low O2, okay? Because their CO2 stays high. Their body's used to that. Okay? Does that make sense? Okay, so you can't put high levels of oxygen. We generally put anywhere from 1 to 2 liters. That's usually about the norm. You may see a little bit, maybe 3, but we try to keep it very low. Okay? So I want you to think of the pink puffer when you're thinking about the signs and symptoms. Again, your alveoli have lost elasticity. Okay? And because of that, what kind of breath sounds might you hear?
Crack.
Possible. Diminished. Yeah, very diminished. Diminished. You know, you may or may not hear wheezing, but very diminished because of the poor gas exchange and the decreased surface area. And like I said, their life revolves around this breathing. They're very controlling patients, They don't like things moved. They cannot tolerate a hot room. And don't you ever go in there and lay flat in the bed, because they will not like it. They have to. A lot of them sleep in a chair. They sleep better that way. Okay? And that is emphysema. Okay? Now, this one, can you reverse it?
No.
No. It is irreversible. Again, one of your big risk factors is smoking, especially patients who have smoked over long periods of time. The difference is, notice what's affected. The bronchioles, exactly. So now you've got that inflammation, constriction, bronchospasm, and major increase in mucus production. These patients are the chronic coughers, or the blue, what do you call them? Blue bloaters, exactly. They are the blue bloaters, okay? Because of the low O2, what do they look like?
Cyanotic.
Dusky, clubbing, what else? All right, fatigued, obviously. In other words, what I want you to think about is anything that impacts my oxygenation status over long periods of time. Can you see them in your mind? I mean, again, you're going to think pink puffer, blue bloater. Okay? Heart rates are up. Oftentimes respiratory rates up. Chronic cougher.
Hemoglobin up.
Chronic cougher. Okay, these are your patients that can contract what? Very easily.
Pneumonia.
Exactly. Pneumonia. Okay, those little upper respiratory infections that you and I are totally miserable but get over puts them in the hospital. Okay, because they are such high risk that they end up in the hospital with a case of pneumonia. And then they're really sick. Okay, and some stop smoking, others refuse. Now, do you think it would be wise to stop smoking?
Yes.
Do you think it can make a difference? Yeah, but can you make them stop smoking?
No.
No. So you'll be amazed at what you see in the hospital. Okay, but unfortunately, a lot of ours end up with pneumonia because they're so high risk. Now, when we get to interventions, we're going to talk about, hey, what are some things we need to assess for, teach, etc., etc. Okay? So these, what questions do you have? Have you got this? You got it? Okay, everybody's good. Great. So now, with our diagnoses, we want to look very strongly at the interventions. Okay? So as you're studying, I want you to get in your mind, again, who are these people? What do they look like? You know, the signs and symptoms, a little brief patho, right, just so it helps you see this person a little better. So now we can care for them. Okay, so our nursing actions or interventions, okay, and this is based on what you know about asthma. So, as far as I'm going to look at, since this is a reversible one, let's first look at this as nurses prevention. What can we do to help our patients prevent a major asthma attack? Okay.
Know and avoid triggers.
Stay on meds. That is critical, even though they may feel much better. Okay? So they need to stay on their meds, their inhalers.
Teach them how to use it too correctly. Make sure they're using all the medicines.
Okay, if they're on inhalers, did y'all go over this?
Bronchodilators, wait 5 minutes.
Come on. There is a question on inhaler. Come on.
We'll use bronchodilators first, and then if there's like an inflammation, and we'll use that after 5 minutes.
Okay, and let's say my patient is not doing this right.
Breathe in slowly, and then you're going to hold for a few seconds, 10 seconds.
Okay,
The need to shake the medication.
okay, and then,
Wait 1 to 2 minutes.
1 to 2 minutes.
Okay.
Between puffs.
okay, good. All right, so
Can
you
you
got
repeat
that.
that as well?
So if they're not using their inhalers properly, it's imperative for you to teach them. This is a huge role of the registered nurse, okay, is teaching. All right? To stay on meds. What else?
They need to know if it's a rescue inhaler or if it's...
Okay, they need to know, is this a rescue inhaler? What might be an example of a rescue inhaler?
Albuterol.
Albuterol. Excellent. Albuterol is one of your short-acting beta-2 adrenergics, okay? So this is a rescue inhaler. Is there any other rescues? What is it?
Adrenaline.
Yeah, I know there was another one that had
Yeah. Okay, look on your chart. What about your cholinergics? Albuterol. Who's on it? Somebody open that book.
Atrovent. Atrovent. Commonly used
Cornelate. We're talking about rescue. Albuterol is the one most commonly seen, but I don't want to throw you off, so everybody look at that chart in your book. Notice how many times I've said that chart in your book. You better know it, okay? And that's fine, you got it? She just mentioned one? Okay, well that's fine.
My life out loud.
Okay, that's fine. The big one I want you to focus on then is what was emphasized to you, because I didn't realize you had this.
Adrenaline.
Well, this is nothing or nothing.
Oh, okay. So I didn't realize you had that. So not to confuse anybody, albuterol is the most common, I will tell you, seen in the hospital. So again, albuterol is going to be your beta-2. Now, as a nurse, I also want you to think about what are the side effects.
jitters, tremors.
Okay.
Irregular heart rate.
Tremors, you will see those. What else?
Hypovolemia.
Huh?
Hypovolemia.
Okay.
Difficulty sleeping.
Okay, yeah.
Dry mouth.
Okay, so again, we've discussed now the rescue inhaler, in particular with our client with asthma. And again, you need to be aware of those side effects, because those side effects can make a person anxious. And that, if they don't understand, what does that do to breathing? Increase the work of breathing, okay? So that's why we have to make sure they understand that. Okay? Also now, because there is a question on this. You need to be able to teach them, what do you know about peak flow meter? Oh, yeah.
Normal levels.
You got to have a baseline. Every patient should have their personal best.
Twice a day, 2 to 3 weeks.
Okay, twice every 2 to 3 weeks. Okay, educate the patient. Go ahead.
Also, like, have them do it after certain activities, because you're not going to be just in bed at home, you'll probably be out doing, so you kind of how it's going to work with activity.
Okay. Now, what does green zone mean?
Good. Good maintenance.
Good. You're 80 to 100% of your personal best. What about yellow zone?
Look for interventions to do for yourself that the physician.
You may need to add like a medication or something.
Right.
50 to 80% of your personal best. So you may need to add a medication at that point. Huh?
Take it easy.
Yeah, watch, really pay attention to your breathing, okay, especially if it's, you know, that season where, you know, even I don't have asthma and the dang pollen around here just drives me nuts. Okay, so what about red? Call, you need to notify your physician because you are now less than 50% of your personal best. Patients need to understand the importance of the peak flow meter, okay, to help prevent them from ending up in the hospital. Okay, something else I want you to teach. Should these patients have a flu vaccine?
Yeah.
Why? What if this is our patient who has, you know, pretty bad asthma and gets the flu? It's going to increase their work of breathing to the point that they could easily end up in the hospital, right? And we don't want that to happen, especially this day and age when, you know, these are so prevalent. We push them so hard now, and that's a good thing. Okay, that's a very good thing. Flu vaccine is given how often? Every year. It's every year. Now, pneumonia vaccine is right. It's usually every 5. But again, those are pneumonia vaccines are seen more with your elderly patient and your irreversible diagnosis, your COPD, emphysema, bronchitis. Okay, so you're going to teach flu vaccine. Okay.
Teach them to avoid crowds and address things, you know, illnesses are going around.
Okay, avoid crowds. Uh-oh, sorry. People are sick. We've already mentioned learning what your allergen, your triggers are, and avoiding that. Okay, now let's talk about, let's say they do come into the hospital. Okay, they're in the hospital now and they're wheezing.
It's better to be there.
It's a good time.
It's better than not wheezing.
No reason.
Okay, so what might you want to do first?
Sit them up.
Okay, obviously you want head of bed up, probably at least, I mean, they can tolerate 90 degrees. Why?
So they can breathe.
Expand, that expansion, okay?
They increase their hydration. Hydration increase.
Okay, increase fluids. That's all, you know, the last thing we need is for thick, tenacious mucus.
Oxygen.
Thank you. Okay, oxygen. Okay, so depending on what the question is asking you, again, these guide you in priorities. So oxygen, head of bed.
Maybe a non-rebreather.
Sitting up.
And again, if you would assess, obviously, if a cannula was not doing the job as far as oxygenation, what provides
Non-rebreather.
Hot, yeah, then we go to mask, and if we had to, we will use a non-rebreather because that provides how much?
Up to 10?
Yeah, the liter's up to 10.
95.
It provides about as close to 100% as we can get with a mask. And again, that's why we turn it up so high, because we have this like one mask fits all in the hospital. So,
They got cracks.
yeah. So oxygen, fluids is critical.
Maybe percussion loosens stuff.
Now it's interesting to me. Back in my day, they called it chest physiotherapy. Now they've renamed it. That's one thing I love about healthcare. They rename things as I get older. So now yours is percussion, vibration, and postural drainage. Exactly. And you guys talked about that, right? About the reasons for that. Because you don't want those secretions to solidify and, again, make everything worse. Increase work of breathing, okay? What about, is this good?
Cough.
Yeah.
Maybe a flutter.
Flutter valves. Sinus barometer.
Okay, flutter valves cause a vibration. Incentive spirometer can help expand. Inspiratory effort, because guys, coughing and deep breathing is the exercise for the lung. Okay, this is the exercise. Okay, and if they can, ambulation as tolerated is until, especially with the asthma patient, but even with others, they still need to get up. But let me ask you this. Is this a patient that you're going to go in there in the morning and say, get up, we got to get your bath, we're going to do this?
No. It's slow, rest.
Very calm, because they're probably on these meds that increase anxiety. If they've had an asthma attack, they've had to work to breathe. It's a calm approach. You guys, you're going to have to space out your activity. Okay? You have to space it out with these patients. Sometimes, again, you have to give them a treatment. They have to have their treatments. And then, good mouth care before they'll even try to attempt to eat. Okay, does that make sense to everybody? Okay. So, again, you want to make sure that you're incorporating nursing, okay, and, which is education, and your collaborative interventions with your meds. You good? The asthma? Okay. Asthma, again, is reversible, so that's a good thing if patients will kind of do what they need to do. Okay, actions with, now we're getting to our, and notice these are often, back in the old days, I don't know, but they're referred to obstructive, right? Obstructive airflow. Emphysema. Irreversible. Right?
Yes.
Okay, so nursing actions. Could this patient be on oxygen at home? Low, maybe low oxygen at home. So if they come to the hospital, are you going to take their oxygen off and get them out of bed and go to the bathroom? No. No, because you're going to do something bad. Okay. So how long is this class?
11:40.
Oh, okay. Well, I'll get through it. Because all we got after this is...
Bronchitis.
Oh, yeah, but pneumonia. Pneumonia is the big one, okay? There's only a couple questions on flu and RSV. Okay, so these are the biggies. And, of course, it's nursing process. Okay. Emphysema, nursing actions. If they're on O2, say at 2 liters, They need to be left on O2 at 2 liters. Now, that means you get an extension cord or whatever, anything else you need to do. Because you can't just take it off and say, here we go. Okay? What about position of the head of bed? Elevated, excuse me. And again, sometimes, especially with your emphysema patients, they like a table so they can tripod position. That helps them breathe. Come on, what else? Meds. Bronchodilators. This is also where you'll see, actually, theophylline, Theodore, those are xanthines. Those are actually very old drugs. But guess where you're going to see them? On these patients who've been on them forever. Okay? So this is where you may see that Theodore, okay, or theophylline, or whatever the case. You guys know your levels. Do you know them for
10 to 20?
I heard you say that early. Okay.
Rated at 35.
Bronchodilators. What else might you see? Since this is chronic, I want you to think of this as chronic inflammation. Steroids. And I heard somebody say, you talked about cushy. This is where you often will see it on these patients that have to take like prednisone, their steroids every day. You can see the mood phase and the weight gain. Yes. Yes. This is often where you'll see that. So again, very important to teach the patient about the bronchodilators because they do not like to feel any more anxious than they already are. You need to reassure them it's normal, it's okay, you know, because your heart rate could increase some, but it's to help you dilate so you can breathe more effectively. This is going to help with the inflammation that's occurring. Now, this has side effects. Hyperglycemia. I'm just going to put increased glucose.
Weight gain?
Yes, weight gain. And another one, I don't know if she mentioned this, but to let you know, this can affect your immune system and depress your immune system. Okay?
And your wound healing.
Wound healing will be decreased.
Healing can be decreased. It affects the skin. This is where you'll see that very thin bruising. So, steroids are great drugs. They're not one you want to be on every day because of the side effects of them. Okay, but these patients, they have no choice. Okay, because it's chronic inflammation that is occurring. Okay, so there's really no choice in that matter. So very important. Okay, let's go to teaching. What do you teach? You've already mentioned it.
If they're not
First lip.
if they're not diabetic,
They may be.
Okay, questionable need for insulin because of the
side effects of it.
teaching the side effects of this medicine.
Yeah, more, teach them about the moon phase. Things would be scary to see if you don't know that's going to happen.
Exactly. And it could be they need their dosage change. So it's very important to teach about the medications. Okay, pursed lip breathing. What else? We mentioned it. What about pneumonia and flu? Vaccines. Like I said, a bad case of flu. Put this patient in the hospital, and guess what? They may not get out. Okay, where you and I survive and move on, that may not be the case for these patients. Okay, they're going to always retain that CO2 and have that low O2. Okay. Now, do you know assessment findings? I'm not going to beat a horse down, but you should be able to identify, looking for the perfusion changes, right? Like I said, you should be visually thinking pink puffer. So nutrition, sometimes they have to eat very small, more frequent meals.
Do they speak in the short, jerky sentences?
Short sentences, you know, they may not can carry on a full conversation with you, especially after they try to eat, okay, or go to the bathroom. Okay, so you have to reassess their oxygenation status, okay, and make sure that they go back, not normal, but what? Their baseline. Their baseline, okay? So, spacing out care. Those are the biggies as well. What else? Can you think of anything? Good? You see good? Just need a little review. And then, of course, we don't really have to change that much, except this patient is, again, these are your major coughers. Not that emphysema is not, but again, irreversible. We cannot change what has been done to this patient, okay? So we've already looked at meds, the teaching of meds. Again, one thing I didn't mention, effective coughing, you know, is not effective coughing. Sometimes you almost have to get them to, you know, I often tell them hold your abdomen, because these muscles are so inefficient now, unlike what we see with you and I. Okay? So effective coughing techniques. Any questions? So far, good. I don't dark quiet. Used to the senior class, they are so loud. Okay, we're getting through this, and I'll show you something. We may not have time. When is this class in? You said 11:40. We may not, but I'll show you what I got, and I can always put it on blackboard. Okay, now, like I said, there's not really that much on flu. Why the big nursing? Yes, ma'am, I'm sorry.
You said that emphysema, that there's an increase in CO2 retention, correct? Okay. I just wanted, I came across that last night studying on the sheets, the funny notes, or funny sheets, like this.
It says decrease.
It says decrease.
It says decrease CO2.
So, you guys.
That's for the
But at first, she said at first it's decreased CO2, and then it ends up being increased.
I did it for notes, and every other one I found said increase.
So it's
I would
increased
go by
CO2?
Increased, yes.
Yeah.
And those visuals are great. They're good for my visual learners, but again, you always have to be careful. Y'all know your textbook is the theory that we use, so, but they're good to help you learn.
In large part, only with the chronic bronchitis.
Excellent. Okay, thank you for reminding me of that. What happens with, okay, again, with your, yes, and that's usually where we see it, okay? With your chronic bronchitis, well, and your emphysema, you can see it as well. But what happens is these pressures within the pulmonary vasculature rise. So when they rise and they stay high over time because of what's happening, then again what happens is this right ventricle is going to take the initial hit. Okay, it's going to enlarge, It's not going to pump as effectively, and that's what we call core pulmonale, right? I think I spelled it right. Is that right?
Yes.
Core pulmonale. And again, your patient's going to have increased shortness of breath, weight gain, because again, the heart can no longer, you think, well, it's gotten bigger. Well, this, it's not, just because it's bigger, this muscle now is not going to pump like it would have before, okay? So again, yeah, so you have actually less blood flow going out, less blood flow coming back, so you have the increased edema and weight gain. And eventually it leads to, guess what? Congestive heart failure. Often your chronic COPD, they're on diuretics because of the damage to the heart. Okay, so, the heart and the lung are being taken. Okay? In fact, the heart and the lung, and eventually you'll learn all the body systems together. So thank you for reminding me of that. Yes, core pulmonale. Okay, stay with me. I know it's a lot, but is it helping?
Yes.
Okay. This, again, I cannot emphasize the importance of hand washing, of course, and vaccination. Because majority of flus, at least can be, maybe not completely prevented, but it can lessen the symptoms. So therefore, maybe this patient doesn't have to go into the hospital. Okay? So again, hand washing and vaccine, we know that this is every year. Okay? It's a virus. Okay? It's like RSV. It's a virus. So really good hand washing, and this is bronchiolitis, often seen in your babies. Okay, you'll see the hospital full of it, the peds unit. But RSV is a virus. Okay, so really all you can do is put mom and baby in a private room, and again, fluids, just what we talked about. Fluids, humidification. Anything that can help, keep those secretions moist. Because little babies' airways are small. And good hand washing. And hopefully it resolves and gets better.
PowerPoint says something about ribavirin, and you can use it for the RSV, but also possibly for something else.
I looked a little bit at that. Those drugs are very expensive, and I don't think they're using those that much. Now, I will tell you with flu, if you get the flu, if you get started on Tamiflu, that can help lessen the symptoms. But what I read for the babies, a lot of those drugs are so expensive that
it doesn't do much.
Because they're so tiny. To really, oxygen if necessary, obviously, but humidification, fluids. Oh, goodness.
Make the airway clear.
Chronic bronchitis out here. Chronic bronchitis. Oh, my.
Ineffective airway clear.
He's coughing.
Swallowed the wrong way, sorry.
Yeah, no, he's coughing. Pneumonia. So now that you've got a visual of your patient, that this is usually what happens. My patient with COPD gets an upper respiratory infection. It doesn't get any better, and because of all the weakened muscles and the coughing and and this, and their immune system, the whole thing, they end up with, and this is how you'll see it abbreviated in the hospital, pneumonia. DNA, pneumonia. Okay. The big thing with pneumonia is it can be caused by bacteria. Okay. Especially if secretions like the alveoli are not functioning properly, diminished sounds because they can't cough effectively, that atelectasis then is just a ground for fluid to seep in. And bacteria, of course, invade that area. What happens is, and this is just FYI, Leanne probably mentioned, you have a change in your capillary permeability, and the fluid then seeps in. So whatever functioning alveoli you have, as they expand, you hear crackles, okay? And of course, crackles, they're going to start in the bases, and it can be one side or both sides, and they will work their way up, okay? So, as a nurse, we know that, again, if this is a bacteria, exactly. Now, with our patient, obviously, they're going, I can guarantee they're going to need oxygen, okay? Because now of the fluid now within the pulmonary system.
Sputum culture first before the MRI.
Okay, excellent. You want to get a sputum culture, right? Why? You guys probably know of the drug resistant. It's taking over. So you want to culture and then start that antibiotic. Okay. This is what is critical to help resolve pneumonia. Okay, I can't change a COPD patient's pulmonary situation back to normal, but hopefully we can control and resolve the pneumonia. Okay, now I want you to picture then, this is your patient now with pneumonia. Okay, they're very fatigued. Again, I've already said you've got to space out care. Right, ambulation is as tolerated. Keep their O2 on. Of course, you're going to need, most of the time, this is going to be IV. So you get your sputum culture, you're going to need an IV because we need some powerful antibiotics to try and clear up this pneumonia. Okay? Turn, cough, deep breathe. Incentive spirometer.
Probably watching for fluid or blood. It's going on IVs.
Absolutely. Very good. That's excellent critical thinking. So you want to monitor them. Now, do they need fluids?
Yeah.
Yes. We can't eliminate fluids. And again, humidification. Did y'all talk about humidification with their oxygen? That you can humidify oxygen? Well, yes, you can humidify oxygen. So those things can help keep those secretions loose because, again, their efforts are weaker, and so they need every opportunity to get this stuff up. Okay? Will they be on bronchodilators? Yes, they will. Might they be on steroids? Could, absolutely. These are also patients that you'll see on the, I think they call them mucolytics now. You guys know, you see Mucinex everywhere. We give Mucinex in the hospital like it's candy, okay? So, and again, I can't emphasize enough the importance of teaching in particular with oxygen. I mean, sometimes they'll take it off. And the importance of them getting their antibiotics. Okay? Taking the bronchodilators. Now remember, you guys are assessing before and after. Taking their meds, even though it has side effects. And our mucolytics. Okay, plenty of fluids. Do you have any questions? Okay, I'll show you what I did. I can put it up. We're gonna, because I know you guys have to go. But you can tell me. This is something I did bad, but there's still, I think, some good things that you might find useful. Okay? But pretty much, guys, I re-emphasize the material that you're going to see. And, you know, I want you to apply the process. Because that's what you have to do in order to answer questions.
Question.